So this is the second part of talking about pain. We have just talked about the kind of historical perspective or the historical discussion of pain, to where we proposed where Melzack and Wall proposed the gait control model, and then we talked about some of the evidence for that, for proposing that, as well as some of the research, not all of the research. Clearly, there's been a great deal of research, and that's just a few studies that is, again, providing evidence for the gait control model, and maybe for the notion that this is a bit more complicated than even the gait control model suggests. So, as is often important for us to discuss in sensation and perception, is what's going on in the brain, and what are the brain mechanisms, what are the brain regions involved. And so far, all of the senses that we've talked about have had this rather straightforward route through the thalamus. Maybe we have some other information being sent to actually, in most of these cases, information is going to be sent to the superior colliculus so that we can figure out where to move our eyes. And we have these other subcortical structures that have been largely ignored. But pain is not so simple. Okay, it gets sent to a couple of nuclei in the thalamus and then sent on to various places. One of the places it gets sent on to is the somatosensory cortex, where I'm actually feeling my body. So I usually do that thing where I point to my left part of my somatosensory cortex, which I don't ever know if I'm quite a little bit too forward, but it may be a little bit too far back. It depends really on how my brain is shaped. People are slightly different from each other. But if I'm touching something with my right index finger and it's burning my right index finger, I'm going to feel that right in my left somatosensory cortex, as it's contralateral, and it's going to be right up there, sort of midway, sort of dorsally, but not at the very top of my head. So I usually do it a little bit slightly down from that area. And you might actually try to go back and look at the homunculus, that body map, that somatotopic map of the somatosensory cortex. It is the same map, regardless of whether I'm talking about the pressure, vibration, tickle, itch, pain. There are layers that are responding to those different sensations, to those different perceptions, but they're lined up in a column so that I still have my finger, still responding to my finger in the same kind of place in the somatosensory cortex. Anyway, so the thalamus is sending information there. It's also sending information to the insula, which I'm going to talk about a bit. I have that off to the side as your author's not pointing to it, but it gets discussed a little bit. And it also sends information to the anterior cingulate cortex up there towards the front, labeled ACC. And for the most part, for the rest of this, I'm going to be talking about those regions, the somatosensory cortex, the insula, and the anterior cingulate cortex. But information goes farther than that. So we've already seen some of the influence of cognitive control. The prefrontal cortex is involved, and information is getting sent up there. Information gets sent to the hypothalamus, so my fight or flight kind of responses and my basic homeostasis. Gets sent to the amygdala, so my classical conditioning and my reaction to fear and anger and other emotions. And it gets sent to the hippocampus, so where I am laying down new explicit memories. And to some extent, for some of those regions, so especially the amygdala I know of, and parts of the insula, that information goes straight to those areas and bypasses the thalamus, and then also everything's still communicating within that. But for the most part, it gets sent to a couple thalamic nuclei and sent on to the insula, somatosensory cortex, anterior cingulate cortex, prefrontal cortex, hypothalamus, hippocampus, and the amygdala. So it's still getting sent through the thalamus as well. But to some of these, it also goes directly. Not trying to make that too complicated, but I just did. So this is considered the pain matrix. All of these brain regions are involved with our experience of pain. I'm going to discuss the multimodal nature of pain. We've actually already seen this, where one of the studies asked the people to rate both their intensity and their unpleasantness. At this point, I usually have students share some of the ways we describe our pain. And you can pause this for a moment and think, how do I describe my pain? And I usually write them on the board. And I try to put them into categories, although sometimes it's difficult to categorize. But we might say, right, I'm going to try and think of some of the physiological ones. So burning, stabbing, shooting, tingling. I'm not very good at ways of thinking of a pain. Yeah. So except when I'm better with then I put those, the ones that are more really describing the intensity or the physicality, the sensation of pain in one category, and then put some of the ones talking about unpleasantness or our affective response to pain in another category. So annoying, torturous, dull is a physical one. I had a student once say crippling. I thought that was a really good one. Crippling, frightful, aggravating, frustrating. All of those are examples of the affective component, or how unpleasant pain can be. So we have this multimodal nature of pain. And here I have that example again, except on the slide, as we're going to talk about, as we just talked about the pain matrix in the brain. And now we're going to look at a particular study, and where in the brain we see activity, and in response to the sensory component of pain. So they give the examples throbbing, hot, dull, and the affective or emotional component of pain: annoying, sickening, torturing, torturous, whatever. Okay. Hochbauer et al. In 2001, participants were presented with painful stimuli and asked to rate both the subjective pain, so the sensory component, as well as the unpleasantness of the pain, so the affective component. They also used hypnotic suggestion to either decrease or increase each of those components. So Hochbauer et al. Measured brain activity using PET as participants responded to their pain as induced by immersing their hand in hot water. And they made these hypnotic suggestions, so either increasing or decreasing the intensity of the pain, or increasing or decreasing the unpleasantness of pain via hypnosis. And so for intensity, they might say something like, this is really painfully hot, it's burning hot. And for decreasing, they might say, this is not particularly hot, it's painful but not too painful, it's maybe just warm. I'm not really sure what they said, but so trying to get at that idea of intensity. And unpleasantness, where they're really trying to increase or decrease. This is really annoying and torturous and hateful, versus this is hot, but it's not annoyingly hot, or it's not really unpleasant, as they try and decrease that unpleasantness. Again, not sure exactly what they said. I have looked this up once, but I've forgotten. It's been a long time since I looked it up. And I find trying to decrease unpleasantness as particularly difficult, since you have to use unpleasant words to do it. Anyway, as they were increasing and decreasing the intensity via hypnosis, again, in all these cases, the hot water is the same temperature hot water. People rated their intensity and their unpleasantness as lower when the hypnosis was suggesting a decrease in intensity. So not only is it less intense, but it is less unpleasant. When the hypnosis suggests an increase in intensity, we see an increase in the ratings of both intensity and unpleasantness. Of course, again, if it's more intense, it's more unpleasant. What's interesting here, though, is not only that they saw these differences in ratings, but that they saw changes in the anterior cingulate cortex and in the somatosensory cortex. So I'm influencing that perception of the subjective feeling of pain or the feeling on the body, and we're seeing changes in the somatosensory cortex in response to that suggestion. So this is what I'm saying with S1 there. And if you notice in the brains, what they're showing from the basics of the PET study is that S1 and S2, and actually they also have P1 there, or PI, that's the posterior insula, that all of those blue areas are the conscious perception of my body, the feeling on my body. And the green areas that they're pointing to, which is the anterior insula and the dorsal anterior cingulate cortex on those two brains, that is going to be, those are the brain areas responding to the affective components. And here again, so I'm increasing and decreasing intensity, and it's not just I'm seeing changes in the activity of the somatosensory cortex as well as the anterior cingulate cortex, so where I would be feeling my unpleasantness. And we see that borne out in the ratings, so those match very nicely. If we go and look at the ratings when they are hypnotically decreasing and increasing unpleasantness, we see people rate their unpleasantness as lower in the decreasing unpleasantness condition and rate it as higher in the increasing unpleasantness condition. So again, the hypnosis is working and it is influencing their ratings of pleasantness. And here it is not influencing their ratings of the intensity, right? This is just really influencing the affective component of pain and not anything to do with the sensing or the feeling of the body in pain. And here, when they look at the PET study or the brain imaging, they see changes in the anterior cingulate cortex, so that area that is responding to the affective component of pain, and no changes in the somatosensory cortex, which again makes sense, so I'm not seeing any change in the intensity, in the perception of the intensity of the pain. So now I've talked about central control as mostly, I've talked about it as cognitive control and even called it that, as what we've talked about is shifting attention and hypnosis and things that influence our cognition and how we're thinking about pain. But that is called, in the gate control model, that's called central control for a reason, because it also involves these just chemicals in the brain that influence our pain. And I've alluded to the adrenaline rush that we might have when we are in battle or when we are in peril, and how that influences our pain and we feel less pain. And that is adrenaline rushing through the body, but that is a chain reaction set off right by the hypothalamus and that fight or flight response. What your author discusses here is endorphins, and so this is again gonna, if that central control is going to have an inhibitory effect, and so the idea is that it's sending excitatory information to those inhibitory substantia gelatinosa. And I'm going to do the little bit of history of how we discovered endorphins. So in the 1950s and 60s, when we started coming up with all these psychotropic drugs, it was because we realized that if there's some kind of drug or chemical that influences people in a psychological way, then there must be some receptor site in the brain that's responding to that, and so there must be in the brain some endogenous chemical, so some chemical that's a part of us, that's within us, that is going to fit into that receptor site. So in 1973, Solomon and Pert discovered endorphins, the brain's natural opiates. And what the picture to the left is showing, so if I have heroin can go into a receptor site in B, I'm showing that same receptor site, my endorphin can fit into those opiate receptors, as they're called. And the other thing that is showing is the effects of naloxone. So naloxone blocks the action of heroin by attaching itself to the receptor site that heroin usually can occupy. And so what it does is it's a direct antagonist for heroin. If we look at A in the picture, naloxone fits into the receptor site of the postsynaptic neuron. It does not influence the postsynaptic neuron, and it basically just blocks heroin from getting into that receptor site. This is actually the treatment, right? For an overdose of heroin, they will inject somebody with naloxone so that it blocks the heroin from getting into the receptor sites of the brain. Well, if we continue to look at this picture, again, we go to B, where endorphins fit into those same receptor sites. What that means is naloxone. We can inject someone with naloxone, and it will block also endorphins from getting into those receptor sites. And so it can block, it also blocks a placebo effect. So it looks like when someone gives us a placebo, they give us a sugar pill for pain specifically, that we release endorphins. And so naloxone is also going to block the effects of placebos. Okay, so this is one of my favorite studies to talk about for a number of reasons. I don't know if you can tell, but I do enjoy talking about pain. I find it fascinating. Anybody who has had pain in their lives or different kinds of experience with pain, you have to be somewhat fascinated by it, because there are still a lot of mysteries, but finding out some of the answers to those mysteries is fascinating. But this is a great study for a number of reasons. This was done by Benedetti and his colleagues back in 1999. And I had an aha moment. And so I'm sharing these descending pathways of pain here, again, from another book. And you don't need to know them, but just so I can talk about my aha moment in this very excited way. So what they did, this is a study that I would have read the informed consent and walked right out and said, nope, I'm not doing this study. You might feel the same way. But what they did was they had participants come in and they injected their left hand, their right hand, their left foot, and their right foot with capsaicin. So capsaicin is the chemical that makes hot peppers hot. And if you've ever chopped hot peppers and then touched your face or your eyes or something like that, you know that it's this burning hot sensation that is terrible. And they injected this into people's hands and feet. And so yes, that right there is something I would never do. And we see people are rating their pain on a scale from 0 to 10. And we see if they had no placebo, they are rating their pain on all of their hands and feet as about the same. Okay, and what Benedetti et al. Did, so in one condition, people had a placebo cream, so they rubbed a cream on the left hand and suggested that this was an analgesic cream, even though it was just a placebo. And if you'll notice, people rate their pain as lower on their left hand, but they're still feeling the same amount of pain on their right hand and on their feet. They also wanted to see if this crossed the body. So some participants were in the condition where they rubbed this placebo cream on the right hand and the left foot. And you can see there that those people are rating their pain on their right hand and their left foot as being lower, but they are rating their pain on their left hand and their right foot. That's still the same. And so what does this show? This shows that, so the idea before was that a placebo is basically just giving us a relaxation effect. And that's not what's happening. Another idea might be, for a placebo, we're just releasing endorphins and it's having this generalized effect on the brain. That's also not what's happening. It is releasing endorphins. We are releasing endorphins, but it's not a generalized effect on the brain. And so for me, my complaint used to be when I talked about the gate control model before seeing this study, I would also complain about the fact that central control and had to go down to those substantia gelatinosa in the spinal cord to have an effect. That didn't make sense to me. But as you can see, if what's happening is we are sending this information down to the spinal cord, to that particular dermatome, then that explains the results of Benedetti et al. That what we are feeling is a localized effect of the placebo, not some generalized effect in the brain, and it must be going down to those substantia gelatinosa in the spinal cord. So I put on here just a reminder of the gate control model, that what we're talking about is a transmission cell sending information about pain to the brain, but where that transmission cell in the spinal cord is getting its information is not just directly from the nociceptors, but directly from the nociceptors as well as from the large fibers as well as from central control. And that central control, according to the Benedetti study and other studies that I haven't talked about, has got to be communicating down to the substantia gelatinosa in the spinal cord. We might wonder how much of that central control might also be having an excitatory effect and how those effects might work. We might want to update this model in our minds, in our thinking, to have a little bit more complicated influences from central control. And again, I'm putting these pictures here from another textbook just because I think it's helpful to look at, not to give you more to memorize. You don't have to be able to see all of these brain regions and so forth, but we see the ascending pathway going through that particular dorsal root, that particular vertebra of the spinal cord, and up contralaterally along the spinothalamic pathway to the brain, to the thalamus and some other areas, and areas from the thalamus communicates to other areas, but that actually goes to some other areas. He ignores, I'm sorry, this was a she, the author ignored any other area than just this primary somatosensory cortex, but we know the brain matrix is much more complicated than that. If we go over to the far right, we're seeing again the descending pathways, and at these descending pathways, we have information coming back down from the thalamus, from the forebrain, but also from areas of the midbrain and hindbrain. We have the paraaqueductal gray, which has a lot of endorphin receptors or opiate receptors in them. But we also have, notice, all the way up at the frontal lobes, all the way up at the prefrontal cortex, there is the possibility of inhibitory information coming down to the spinal cord. So those are descending pathways that so that would be central control influencing my experience of pain. And again, whether or not that's truly just inhibitory or inhibitory maybe excitatory, you need to think about that. There's no easy answer.